I'm Rod Rourke, and I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the July 2017 edition of the PRS Journal Club podcast. I'm Chad Purnell, PRS Resident Ambassador from Northwestern, and I'm joined by my co-ambassadors Jordan Frey from NYU and Dr. Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Noopur Gangopadhyay, craniofacial surgeon and microsurgeon and assistant professor at Ann and Robert H. Lurie Children's Hospital of Chicago. Thank you much, Dr. Gangopadhyay, for joining us for this podcast. The article we'll now be discussing is Spring-Assisted Cranioplasty for the Correction of Non-Syndromic Scaphocephaly, a Quantitative Analysis of 100 Consecutive Cases by Dr. Will Rogers et al. From the Great Ormond Street Hospital for Children in London in the UK. As a quick reminder, all of the articles that we will discuss tonight can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So just to give a quick introduction to this article, there's a lot of controversy in the management of single suture sagittal craniosynostosis. Some authors prefer suturectomy with postoperative helmet therapy or spring distraction, and others prefer total cranial vault remodeling. There are different age groups at which patients can undergo these different procedures, but there's certainly a significant amount of debate between which of these procedures are appropriate in which situations. The treatment for sagittal craniosynostosis got expanded whenever Luritzen and his colleagues introduced spring-assisted cranioplasty in 1998 as an alternative, minimally invasive method of treating sagittal synostosis. This method avoids the placement of a helmet after suturectomy by placing springs that push the parietal bones apart as opposed to having a more restrictive helmet postoperatively. And this study by these authors is the largest series of spring cranioplasty in the literature today. This is a retrospective review of a prospectively maintained database of spring-assisted cranioplasty patients at the Great Ormond Street Hospital that were done between 2010 and 2014, which represented the first 100 cases of spring placement for sagittal craniosynostosis. They excluded all syndromic patients, and they also excluded any patients that had more than just the sagittal suture fused. The patients, regarding their indications for surgery, the patients were offered a spring-assisted cranioplasty if they were under 6 months, and then the authors also noted that occasionally, if they were over 6 months but less than 1 year, they would offer spring-assisted cranioplasty. The technique that they used is they place the patient in a sphinx position, and then they make a single transverse incision at the midpoint of the sagittal suture, and then they perform parasagittal craniotomies from the coronal to the lambdoid sutures. They use in-house designed springs, and they place 2 of these in the grooves in the parietal bones. And ideally, whenever they're choosing their spring strength, they want to see about 1 centimeter of expansion right on the table when they put the springs in. They close over a drain, and they remove that within 24 hours. They leave the springs in for 3 months, and they don't remove them until they confirm on an X-ray that they've been fully activated. They collected the operative and demographic data, and they also measured the cephalic index of these patients at preoperatively and also on postoperative day 1, 3 weeks post-op, and 6 months post-op. So the results that they got, they included 100 patients. Most of them were male, as we've seen with sagittal synostosis, and their mean operative age was 104 days. Their mean operative time was right around an hour, and their hospital stay was right around 33 hours. For their spring removal, they had a mean operative time of 37 minutes and approximately 10 hours in the hospital stay overall. Whenever they calculated their cephalic index, they did this from X-rays, and 82 patients had imaging that allowed the calculation of cephalic index. So unfortunately, only 23 patients had acceptable radiographs at the 6-month time point. So whenever they calculated the change in cephalic index at each of their time points, at day 1, they noticed a mean change of 3.3. At week 3, they noticed a mean change of 4.5 and a mean change of 4.4 at the 6-month time period. Blood loss is important in these cranial vault type cases, and they noted that 8 patients were transfused during the initial surgery, and 1 patient was transfused for spring removal. And finally, they also kept track of their complications. They had 9 complications. They had 2 dural injuries, 1 subgaleal hematoma, 1 patient had a spring exposure, 1 patient had a CSF leak that required reoperation, 1 patient had a CSF leak that required a lumbar drain and then eventually developed meningitis. One patient had a bony defect that required a reoperation. And then finally, one patient had a subdural hematoma that resulted in an infarct. They overall had a 5% revision rate. 3 patients had a revision for increased ICP, and 3 patients had a revision for head shape. Overall, the authors conclude that the spring-assisted cranioplasty is an effective procedure and has minimal operative time and morbidity. Their results regarding cephalic index appear similar to those of strip craniectomy with helmeting postoperatively. They do note that undercorrection can occur more commonly than in a total vault remodeling, but they said this is in a minority of patients. And then finally, they also discussed their most severe complication, which was that subdural bleed that resulted in an infarct. And they noted that they modified their craniotomy to help avoid this in the future. I thought this was a pretty important paper because this is a technique that's kind of taking off, I think, at certain centers. And we need large studies to determine the results of spring cranioplasty, especially in comparison to total cranial vault remodeling and minimally invasive suturectomies with postoperative helmeting. I think that the authors showed a modest improvement in cephalic index is possible with the springs, but certainly this procedure has a lower operative time, less hospital stay, and less transfusion than a total vault remodeling that may get marginally better cephalic index results. The complication profile of this procedure I thought was still low, but they do highlight that the complications from this procedure are not zero. And if you do have a complication, they can be significant. So I think that's important for counseling purposes. I think the most important question, though, really is what happens in the long term. And really, with 6 months of follow-up, we just really don't know what's going to happen in the very long term after this procedure yet. So I think long-term studies, I'm hoping they continue to follow this cohort out and see what happens to their skull shape in general. I think also it's important to keep in mind that they're measuring cephalic index, which is not a perfect measure of the deformity in sagittal craniosynostosis. And so things like occipital bulleting, temporal pinching, frontal bossing, they're not collected in this study, but those things are difficult to collect in general. I hope that whenever they collect more long-term data, that they'll also collect those kind of things and just see how the overall head shape looks along with cephalic index. With that, Dr. Gangopadhyay, I'd love to turn it over to you and see what you thought of this paper.
I agree with you, Dr. Purnell. I thought the paper was excellent in really representing a large cohort of patients and certainly the largest series of spring cranioplasty patients for sagittal synostosis that I have seen in the literature. The interesting thing about their technique and the interesting thing about spring cranioplasty in general is that the majority of these springs are often homegrown. So they are usually specific to a single institution, which kind of allows the surgeon to modify them. The interesting choice in this article is that their technique is slightly different than other centers that do spring cranioplasty, and that they don't do a true sagittal strip craniectomy. They're actually making parasagittal osteotomies on either side of the fused suture, and then in the central location, mainly for visualization of the dura and the sagittal sinus, they do a full craniectomy centrally. And then they're actually putting in 2 sets of springs, and the tension on the spring is actually determined intraoperatively by the surgeon, which they didn't go into great detail. The interesting thing about this study as well is that there's not a whole lot in the discussion about the comparison between a comparative technique, which I really think would be the endoscopic or minimally invasive sagittal strip craniectomy with a restrictive molding helmet postoperatively. And I actually think that would be a very interesting cohort of patients for them to follow if there's another multidisciplinary center where they could look at those 2 cohorts together. In general, though, I thought the paper was very well written and brings up a lot of interesting discussion points about how we're treating non-syndromic sagittal synostosis and how some of this treatment is actually very center dependent.
Yeah, I agree. I think that if you're going to compare 2 procedures, I think you're right, that comparing this to the suturectomy and postoperative helmeting, I think is going to be a key comparison to perform down the road. And that actually brings me to a question I wanted to ask you, which is, what do you see as the advantages and disadvantages of doing a spring cranioplasty as opposed to doing a suturectomy with helmet therapy?
Some of the advantages are probably similar for both procedures. So certainly for both the strip craniectomy with postoperative helmet and the spring cranioplasty with a strip craniectomy, you are able to operate on these children at a much earlier age. Studies looking at the two cohorts separately have shown that they have much lower rates of blood loss, much lower rates of transfusion, a shorter hospital stay, less need for intraoperative monitoring, such as an arterial line or a central line, and much shorter time to discharge. The other interesting thing is that there are several centers that are getting routine postoperative CT scans and preoperative CT scans. And with this earlier intervention, you do see some changes in the cranial base, which you may not get when surgery is delayed until the child is 12 to 14 months of age, which is more standard with total calvarial vault remodeling. So I think the advantages of both are somewhat similar. I think where they diverge a little bit is sort of the intraoperative decision-making and some of the postoperative protocol. So I think one of the disadvantages with the spring cranioplasty is that, of course, you have to take a young child back to the OR within about 3 months for a second operation to remove the hardware, essentially. The other challenge I see is that depending on what center you're at, you may have different tension on this spring. So how much actual expansion you get of the parietal bones potentially is dependent on the material you use, the tensile strength of the spring, and then what your time frame is from placement of the spring to removal of the spring. Whereas with an orthotic helmet, it's really one operation, and then you're relying on molding afterwards to improve the head shape by restricting areas that have overgrown and allowing for expansion in areas that essentially have undergrown. That said, the helmet itself comes at a cost. Certainly, most children require one helmet, if not two, in the first year of life, and that requires potentially more frequent follow-up appointments with the orthotist and or the craniofacial surgeon that's evaluating the patient. From a cost standpoint, I would imagine that operative time is precious, so even a 30-minute operation or a 60-minute operation to remove these springs would potentially be more expensive than postoperative helmet. That said, the interesting thing is this study was done in a location that has a nationalized health system. So potentially the cost from the extra operative time or overnight hospital stay versus the cost from a helmet would not necessarily be translated to the patient. That's not an issue they may have to deal with in the national health system, but it's certainly an issue we have to consider for our own patients in the United States.
Yeah, I think those are great points. And I think that really, until we get more long-term data, the jury's still going to be out on a lot of these things. Jordan, what did you think of this paper?
I agree. I thought it was a really interesting paper, and like we mentioned, it's the largest series of these patients. So I think, again, it's interesting, and as time goes on, we'll learn more and more, and really comparative studies are what's going to set this apart or kind of confirm the superiority of the more traditional techniques. I did kind of read with interest. They were very honest about their complications, and especially their largest complication, which is on hemiparesis and is serious and something to consider. I'm just wondering, what do you do with this procedure, with all of your procedures, to kind of specifically protect the sagittal sinus, as I think that's a really important point, especially for residents as we're seeing and learning about these techniques?
I think in general, both with the minimally invasive or endoscopic strip craniectomy with a helmet or a spring cranioplasty, I think the approach to the sagittal sinus is actually very similar. At the end of the day, you really want to have direct visualization of that sinus, whether you're doing a total calvarial vault remodeling or a limited access, limited visualization approach. And, I think in this paper, as well as in other papers that discuss technical details of how to perform a strip craniectomy, I think there are three things that stand out. One, anything you can do to try to minimize the blood loss postoperatively and intraoperatively are ideal. So some centers have directed blood donations. Other centers will give their patients tranexamic acid preoperatively to help decrease the risk of blood loss. The second is really exposure and visualization. So you end up trying to make small incisions, and those can either be in front of the anterior fontanelle, posterior to the anterior fontanelle, or in this case, they do kind of a longer incision that splits the distance between the two. But again, the access to the cranial vault is usually in a subgaleal plane, with making sure to completely strip the scalp tissue from the bone itself, and then entering the space between the dura and the calvarium through visualization either from the anterior or posterior fontanelle. In this case, they added an additional craniectomy centrally, but I also think that is probably a function of their technique. Because in general, how strip craniectomies have been standardly described is that you're doing a complete suturectomy centrally, but if you approach from a parasagittal plane, then potentially you're getting into more of those cortical bridging veins and potentially tributaries into this sagittal sinus. So I think the most important thing is trying to minimize your blood loss and getting direct visualization with any technique to protect the sagittal sinus. I think the other thing that's important to talk about is what do you do after the bone has been removed, and whether you're using a camera or direct inspection, really looking at the dura and making sure there aren't any dural injuries or injuries to the sagittal sinus. And then, especially with the endoscope at least, there's also an instrument called a suction coagulator where you can actually irrigate, suck the smoke, and then coagulate the cut bone edges to help minimize your bleeding risk. This risk of getting into the sagittal sinus, I think, is certainly a little bit higher with the minimally invasive approach and with a spring cranioplasty than it is with an open approach, but it's not unheard of with an open approach as well. And unfortunately, it's a very rare but dangerous complication that we have to be aware of and that we have to counsel the families appropriately about.
Thank you. I think those are really important points, like I mentioned, especially for us as we're kind of seeing and learning to do these procedures. Shuja, what were your thoughts about this paper?
Overall, I really like this paper. I think that the most notable results were operative numbers and specifically time, for insertion, removal, low numbers of patients requiring blood transfusion, kind of everything that Chad had mentioned before. And that's not only good from a minimally invasive standpoint, but even from an overall cost standpoint. I agree with Jordan that they went into a pretty honest discussion of their results and how they modified their technique to prevent those complications from happening again, which was good. I agree with Dr. Gangopadhyay. I would have liked to see a more in-depth discussion about how they chose their springs or how they designed their springs. But, as they showed that there were very little revision rates overall, and at the end of the day, no matter what the numbers are, a low reoperation rate, I think, is pretty powerful. So, Dr. Gangopadhyay, I wanted to ask you, I know you touched on some of these points already, but could you give us a general sense of your algorithm for choosing these various techniques for isolated sagittal synostosis in kids less than 6 months and over 6 months?
Certainly, I'm happy to comment on that. So I think in general, when I think of who is going to be offered early intervention and who's going to be offered late intervention, there's two components. Certainly the first is the referral. So if they're entering a referral to a craniofacial surgeon before the age of 6 months, so around 3 to 4 months of age, then I think the option of doing a minimally invasive approach is still on the table. The other component that I'm thinking of when I'm seeing these consultations is what are their other underlying medical diagnoses? So in the situation that they have a syndromic diagnosis, I potentially might be a little bit more hesitant to move forward with surgery immediately until I'm sure that the workup has been completed. Certainly if they have other cardiac or pulmonary issues that may prevent them from going to surgery sooner, then the discussion might sway the parents towards total calvarial vault remodeling at a later age when I feel the patient is medically stable. The other option, and the most important part, is really having this multidisciplinary approach to these patients. So if you have a neurosurgical colleague that does not have buy-in to either an endoscopic strip craniectomy or to a strip craniectomy with a spring cranioplasty, then certainly you're going to have a much harder sell to the parents. At the end of the day, these surgeries should be done with both a plastic surgeon trained in craniofacial techniques as well as a neurosurgeon to improve the outcome as well as to decrease the morbidity and mortality to as low as it possibly can. In my hands, for isolated, non-syndromic sagittal craniosynostosis, I feel that the suture strip craniectomy, whether you do an endoscopic approach or a minimally invasive kind of limited access incision approach with a postoperative orthotic helmet, is really a powerful technique. And I would offer it to all of those patients that meet those criteria where I feel they're safe for surgery and it's an isolated synostosis. For the children over the age of 6 months, I know that in this paper for the spring cranioplasty, they did operate on some of these children and offered them a spring cranioplasty with the strip as well. In my experience, I found that after the age of 6 to 8 months, the bone is much firmer, it's thicker, the rates of bleeding are higher, and it's not quite easy to just simply cut the suture out with a pair of heavy Mayo scissors. And so for those reasons, I tend to offer children that are just presenting to me in a delayed fashion with a sagittal synostosis, the total calvario vault remodeling around the age of 12 months. And certainly if their medical conditions preclude them from having an early operation, or they have hydrocephalus or Chiari malformation, etc., that would require further workup from a neurology and neurosurgical background, then I certainly think those children, we tend to wait and offer them total calvario vault remodeling.
Great, thank you. That was a good overview of your choices for these patients.
Now that we've discussed this article a little bit, Dr. Gangopadhyay, I wanted to ask you one more question. This is Chad again. How important do you believe it is to develop validated patient or parent-reported outcome measurement tools in assessing craniosynostosis outcomes?
I think that's really the next wave of evaluating our results. Certainly, Dr. Pusick and her collaborators have really pioneered the use of patient-reported outcomes in plastic surgery. And starting with breast reconstruction, which is one of the most prevalent categories of reconstruction that we do, I think there's really excellent data to show that we as surgeons don't always understand, even from the patient consultation and long-term relationships with these patients, what's the most important factor of their reconstruction and their sense of self after breast reconstruction. So I think in a similar fashion, really developing these algorithms and outcome measures, whether they're verbal or whether they're written, and standardizing them for children is really important. Certainly, a lot of the metrics that we're measuring in clinic are related to what we as surgeons think are the appearance factors, or have we improved the cephalic index or pictures from 3D MD. But we may also be measuring things like IQ. Just to go back a little bit, I think some of the metrics that we feel are important may not be important to the parents. And certainly it's hard to ask an infant or to reliably get a sense from a toddler how they feel about their surgical outcome. So I know that Karen Wong from the Hospital for Sick Children in Toronto has really been working quite extensively on cleft patient-reported outcomes, and I think the next phase of that is to roll out these outcome measurement tools for craniofacial patients. And I think it's really important because, as we've seen in other areas of plastic surgery, there's a disconnect between what we value as surgeons and a surgical result and what the patients, and in this case, the parents and the patients, may value. So I think it's certainly the next phase of what we should be trying to do, other than just assessing somewhat objective measures as IQ, head shape, cephalic index, or measurements made on a 3D photograph.
I think that's a great point, and I think this has been a great discussion of this article, and I think with that, we'll end our discussion. Remember to tune in to the other two articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcast that will be broadcasted every month. Also, don't forget to participate in our monthly Twitter #PRS Journal Club, where we will be able to interact directly with this month's selected articles' authors. And thank you again, Dr. Gangopadhyay, for joining us.
Thank you so much, Chad.